Good morning, everybody. I'm going to talk about the database that was released last July from 2005 and 2008. We compare laparoscopic and open colon resections. The NISQIP database is a database that we have in 220 hospitals in the United States. They measure 136 perioperative variables, and it's de-identified information. The data collection is done by a paid, trained medical personnel, and to double quality control, they go through the site, they visit the site, and they ensure 90% of the data is accurate. CPT codes and ICD-9s were used to confirm the diagnosis. In general, for general surgery, the strongest predictor of postoperative mortality is functional status, ASA classification, albumin, and age of the patient. In our database, we had 17,000 patients for almost 5,000 laparoscopic colorectal resection, 12,000 open resection that we compared. In this busy slide, we have some difference here. The age group of the open resection is a little bit older, 63 years of age. There was more attending supervision during the laparoscopic cases, and the wound classification was dirtier in the open group. Preoperative characteristics, age, as I said, ASA classification, a little bit higher on the open group. The functional status also, they come sicker patients in the open group. And calculating the NISQIP predictor of morbidity and mortality, we have a higher chance of getting sick if you get an open surgery. These are the preoperative characteristics of our patient, and the ones outside the table is the one that the open surgery had worse. So all the open surgery candidates, they smoke more, they had more dyspnea, they had more DNR written in the chart, they had more COPD, the functional status was worse, and all of the other ones on the right side of the table also. The total number of operations we had in laparoscopic group, 3,000 partial colectomies and 1,300 laparoscopic colectomy. It's not easy to define what type, specifically type of surgery you have. Regarding intraoperative analysis, we had more transfusion done in the open group. The average time of operative time, anesthesia time, was almost the same. And the open group had more intraoperative adverse events, cardiac arrest, myocardial infarction, and unplanned intubation. Here's a postoperative complication. Laparoscopic surgery had less length of stay, and almost all those variables on the left, DVTs, wound infection, ventilator for more than 48 hours, renal failure, CVAs, all these clinical complications were worse in the open colectomy. So we had a less length of stay in the laparoscopic group. The mortality was higher in the open group. Doing the Kaplan Meier analysis for 30-day survivors, we have less death in the laparoscopic group. And here we have a multivariable stepwise analysis of the predictors of outcome. So on the right side, we have the data that favors laparoscopic group. The length of stay is going to be better. We have more return to the OR in the open group. We have less dehiscence in the laparoscopic group. We have less failure to wean, renal failure, cardiac arrest, and septic shock in the laparoscopic group. So in conclusion, we have that laparoscopic surgery is overall superior to open colon resection, improved survival and length of stay, yet the patients undergoing open resection, they have more comorbidities that might explain the worse outcome, and certain outcomes favor open resection. So the next step is to do a statistical analysis and do a risk adjustment for the comorbidities. And prospective match randomized trials are necessary to dissect those errors we have here. Limitations of the study. NISQIP provide a 30-day follow-up, not more than that. Disease-specific information is not done. It's unknown. The cause of death is unknown. Indications for surgery are unknown. And the exact type of operation is difficult to find. Thank you.